From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
I'm Greg Marcus from UCSF and Associate Editor for Cardiology at JAMA. I'm here with Jason Roberts, who is a cardiac electrophysiologist and genetic arrhythmia specialist at McMaster, and a scientist at their Population Health Research Institute, who recently co-authored a preliminary communication published in this issue's JAMA called A Clinical Diagnostic Test for Calcium Release Deficiency Syndrome. And I should mention the other senior author is Wayne Chen at the University of Calgary. So in getting started, Dr. Roberts, if you can tell us a little bit of background context, and it seems there are two parts to that. One is the relevance here to the evaluation of patients with resuscitated sudden cardiac arrest, as well as a bit about this calcium release deficiency syndrome.
Thanks very much, Greg, and it's great to be here. So unexplained cardiac arrest is a major issue. When someone has a cardiac arrest, the initial evaluation generally involves an ECG, an ultrasound of the heart or an echocardiogram, and an assessment of the coronary arteries. And in a majority of people, that is able to identify a diagnosis. But in a certain portion of people, particularly young individuals, no cause of cardiac arrest is identified following those investigations. After that, we increasingly recommend deeper phenotyping that usually involves a cardiac MRI, treadmill test, and genetic testing. But despite all of those investigations, there's an important portion of cardiac arrests that remain unexplained. And that poses a problem both for the person that's affected. If we don't know what caused the cardiac arrest, how are we best to prevent another cardiac arrest? And given that there's a concern a lot of these are genetic, there's the potential for family members to potentially be vulnerable. And if we don't know the cause, they may also be vulnerable to similar catastrophic outcomes. So in that context, calcium release deficiency syndrome, or CRDS, we think that is a new condition that we first described in 2021, and Wayne Chen from Calgary really drove a lot of the data and evidence that helped establish this as a new syndrome. It's caused by a genetic change in the gene called RYR2, which encodes for the cardiac ryanodine receptor. Genetic changes that cause an overactive RYR2 protein are known to cause a condition called CPVT, or catecholaminergic polymorphic ventricular tachycardia. CPVT we can diagnose clinically. If we put patients with CPVT on a treadmill test, they usually get a lot of ventricular ectopy with exertion that abruptly goes away with recovery. The challenge with CRDS, now that we know it's a condition and something we need to look for, we still, up until now, have not had a way to clinically diagnose it. So when patients with cardiac arrest or malignant syncope are identified to have an RYR2 rare variant, and the phenotype is not consistent with CPVT, the question is this RYR2 variant an incidental finding that's unrelated to the presentation? And about 3 to 4% of the general population has a rare RYR2 variant. So in a lot of cases, it won't be relevant. Or is it potentially the cause of the presentation? And so Wayne's work had established that RYR2 loss of function results in CRDS, and they have an assay or assays in their lab that are done in vitro to characterize the loss of function. But the vast majority of clinicians don't have access to this kind of testing. And as a result, we think that the overwhelming majority of global cases of CRDS still aren't diagnosed. So that's kind of the background.
Great. And I should mention, and please elaborate on this, that if, for example, a family member is found to have fairly good evidence of also carrying the same mutation, there's a good chance their life could be saved with a implantable cardioverter defibrillator. So it's not that we or you electrophysiologists are seeking this out without any purpose in mind. It really is a kind of a life or death sort of situation. Do you have any comments on that?
Yeah, it's a great point. So we're still learning about how best to treat CRDS. It was, just reported in 2021. And at this point, we don't have robust data on what medications are effective. In the same context, risk stratification is still in its infancy, I would say. We're hesitant about, do all patients with an RYR2 loss of function variant need an ICD? Probably not. We've learned from other inherited arrhythmia syndromes that the risk of having a malignant event, assuming people are managed appropriately, is often low, and oftentimes we can avoid an ICD. An exception, though, certainly is symptomatic patients, we feel at this point. So someone has a cardiac arrest and it turns out their brother has been having malignant syncopal episodes and ends up carrying an RYR2 variant, then absolutely their insertion of an ICD should be potentially life-saving in that kind of instance.
But I imagine that the challenge here is that the presenting symptom may unfortunately be sudden death. So with that context, tell us what you found.
Absolutely. So the issue with these patients, CRDS patients, is that everything tends to be normal or conventional testing. So ECG, echo, Holter, treadmill, everything's normal. And there's lots of examples now of people presenting to cardiologists with concerning fainting. Testing was completely normal and patients were reassured, and then unfortunately they would die a year later. So there was definitely a critical need to try to identify a clinical test. So Wayne's team has been looking through the literature at published RYR2 variants that were either implicated in CPVT and potentially, misdiagnosed CPVT was actually CRDS, or just kind of generally reported that they think are candidate CRDS variants. And they found a paper from an Israeli group, Dr. Belhassan was involved, that the family had an RYR2 variant M4109R, and interestingly, they commented it's an atypical CPVT family. Multiple people that have this variant have had cardiac arrest or sudden death, but interestingly, none of them had positive treadmill tests. So they had done EP studies in these patients, so that involves pacing the heart, and they found that after a brief episode of fast heart rate mediated by pacing and a pause, the subsequent sinus beat had a really tall T wave that was also broad. So this is not something that we see regularly, as you know as well. We do pacing in the EP lab all the time, and this is not something that we see in normal individuals. So Wayne emailed me and said, is this potentially a way to identify CRDS patients if this is real? And of course, in this context, they characterized the M4109R variant. It turned out it was loss of function. We were in touch with the Israeli group and explained the findings, and that family's diagnosis was revised to CRDS. So then we set upon trying to see whether or not this was something that was observed in other CRDS patients. So the test has now been done in the JAMA paper in 10 patients, and each time we see this pronounced tall T wave that's also broad, so the QT interval also prolongs. And then we look to see whether or not it was present in control patients. So we looked so far in about 45 SVT patients, so patients with structurally normal hearts and benign arrhythmia. We don't see it there at all. We've looked at it in 10 unexplained arrest patients. 2 of those 10 unexplained arrest patients actually had rare RYR2 variants, so they were candidate CRDS cases. Wayne's lab was blinded to the results of the testing. It came back negative, and they came back and said this RYR2 variant doesn't cause a functional effect, which aligned. And then we did it in a few CPVT patients as well. So it looks promising. It's still early days. Our study is going to evaluate a larger number of patients, but it looks promising. And coupled with the human data, Wayne's lab also did studies in mice. So they had CRDS mouse model as well as wild type mouse model and CPVT mouse models, and the same findings were observed. So the CRDS mice, very tall T wave and long QT after brief pacing and a pause, whereas that's not observed in either CPVT or normal mice. And they take a step forward as well. And the benefit of mice is that you can look directly at their hearts. With calcium imaging, they start to unravel the mechanism as well.
Great. And unfortunately, we don't have any visuals on this podcast, but I would encourage our readers to take a look at these examples, which are really quite striking. This is not a EKG finding that requires getting out your calipers or doing any special measurements. It's immediately obvious that you look at that QRS-T complex following pacing, and the T wave is remarkably large and clearly very different than the sinus rhythm T wave. So something that, again, is perhaps readily recognizable and readily actionable if only we know to look for it. This is a preliminary communication, and so that is very explicitly meant to communicate that there's still much to do, but perhaps a valuable and even practice-changing finding. So curious now at this point, Dr. Roberts, how are you thinking about how these findings should currently change practice, if at all, and then what are the next steps going to be?
Yeah, so it's still early days. And as you indicated, we need larger numbers to confirm our findings and make sure that they're robust. But in unexplained arrest patients now, we do broad panel genetic testing as kind of standard of care. And if an RYR2 variant is identified and the phenotype is not consistent with CPVT, I think it's reasonable CRDS should be considered. We know that already. And in that context, doing this pacing maneuver, I think is reasonable to do. We, as indicated, it's early days. So our study, it's called the Diagnose CRDS study. We encourage anyone that has these kind of cases to get in touch with us. We'd love for them to participate with us. All patients in the Diagnose CRDS study will have their RYR2 variant characterized in Wade's lab. So we'll be able to definitively tell them that's the gold standard right now for CRDS diagnosis if they truly have it. But in the same context, the pacing maneuver will hopefully be informative as well. But we have to corroborate the findings with the larger study. And that would also align as well with malignant syncope as well, beyond just unexplained arrest.
I should just add as maybe a public service announcement in general that when someone presents with resuscitated cardiac arrest without a clear reversible cause, that an EP study is indicated, even if you already know that patient's going to be receiving a defibrillator. There are potentially ablatable rhythms that could be responsible and that could avoid subsequent inappropriate shocks. And as Dr. Roberts alluded to, this sort of ventricular pacing is just a routine part of every electrophysiology study. This is not difficult to do. In fact, one could retrospectively review prior electrophysiology studies, and there's always going to be ventricular overdrive pacing. This is also something that can be done via a pacemaker or a defibrillator, just using a surface lead, 12-lead ECG. I should also add from the editor's perspective that this is a fairly unique manuscript for JAMA to publish, but we hope that it demonstrates our interest in cutting edge, new sorts of concepts and evidence-based ideas that may really be practice changing. This was also especially unique in that it included mouse models. There's not a plan to suddenly transition to translational or basic research, but that sort of evidence will certainly be considered if it helps support clinically relevant findings. So I want to congratulate Dr. Roberts and Dr. Chen and all of the authors that contributed to this important and exciting finding that, as Dr. Roberts alludes to, will require further study to help us really come up with confident conclusions. So with that, again, I want to thank Dr. Jason Roberts from McMaster, and I'm Greg Marcus from JAMA. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks very much for listening.